My name is Andrew White. I direct the Center for New York City Affairs here at the New School, which is part of Milano, the New School for, it's got a new name. Let's see if I can get it all correct. The New School for International Affairs, Management, and Urban Policy. I think that's it. Thanks very much for making the time to come today. First, I just want to give a quick plug for the school. We have degree programs, both master's and PhD programs, and a vast range of specializations ranging from nonprofit management to environmental sustainability, politics and advocacy, community development, public finance, social policy, and so on. And in addition to teaching at the school, I direct the center, which is a think tank within Milano, which aims to drive innovation in social policy, primarily in New York City. We do a lot of work on public education, child welfare, child and family services, and you can read more about all of that on our website at centernyc.org. We also organize quite a few of these forums each semester, and our aim is to engage public officials and practitioners and advocates, parents, and others in discussions about the policies that are affecting their lives or that they are trying to put into place. I want to thank the Milano Foundation and the Cyrus Fund for making this possible, and I want to thank Mira Orrick, Karen Mirowitz, and Anna Schneider for putting it all together this evening. I don't want to take up very much time with an introduction because we actually have to be out of here at about 7:15 because there's another event afterwards. But we've got a lot to discuss, and there are many people in this room, including most of you who know more about the details of Medicaid than I could pretend to do. But I do want to say that the debate around Medicaid and healthcare entitlement programs in general is politically loaded now, perhaps more than even in past years. And I also find that that debate often skirts some of the most significant issues. For example, how often do we read in the newspapers that Medicaid is the health insurance program for the poor, when in fact, as most of us know, it is also a vast source of health funding and long-term care funding for very middle-class people, whether elderly or disabled or otherwise, and yet that fact does not seem to be confronted directly in much of the discussion. I think the commission that we're going to talk a bit about today did do a bit of discussion around that. We'll hear today how much they actually confronted it head on or not. As always, we'll do our best to keep the session as conversational as possible. And here's how it'll go. We're first going to hear short talks from our visitors from the Cuomo and Bloomberg administration. And then I'll introduce our moderator and the rest of the panel. And at some point, about an hour from now, there will be time for audience members to pose questions and try and get your own voice in the discussion. As I said, we have to end right on time this evening, so forgive me if I cut you off when you're trying to ask a question. So James Helgerson became Medicaid Director for New York State just a few months ago. Came here from Wisconsin after doing similar work, and he had to lead this commission that drove a number of proposals ultimately through the budget process, which just completed. Mr. Helgerson.
Well, good evening. It's good to be here. Actually, it's good to be here for a number of reasons. And first and foremost is that it means that my life is going to be a little bit more sane in the coming days and weeks. I am a proud survivor of the New York State budget process, and for any of you who have been part of that process, it is a unique experience for human beings. I've never had so many meetings that were actually scheduled at 4 a.m. Didn't realize that that was such a thing, but glad to be here to begin talking about a final product that I frankly am quite proud of. I think there's a lot of important reforms that have been put forward as part of that product, and while there's a lot of work to be done, including work by the team that I helped lead, but also in terms of implementing the many items that made it all the way through the budget process. But just to give you, and I've been told, just keep my remarks short and really have it be mainly, as it was said, as a dialogue between us, is just to give a little bit of a recap of how we got here and I got here today. Back on the 5th of January, Governor Cuomo created through executive order what's called the Medicaid Redesign Team. It was a group of 27 individuals from across the state representing a variety of different interests, stakeholders. That group was given a very challenging task to find $2.85 billion in state share savings in the Medicaid program, and basically to try to do that in approximately a month and a half. The group attempted, to the best it could, to travel the state to hold public hearings. We attempted to engage the public and to engage the stakeholders in generating ideas. Through that process, we generated over 4,000 ideas. In fact, we generated so many ideas that it was very challenging for us to keep track of them all. And also to try to analyze as many of them as we could to put together a comprehensive package that the team could consider, and then hopefully, it was our goal, was that they would endorse a package that would then be sent on to Governor Cuomo for his consideration as the budget moved on. And so on February 24th, the team met. They were presented with a draft package. They accepted those recommendations. They were forwarded on to Governor Cuomo, who then put those into his budget in the form of a 30-day amendment, which then began the budget process, for at least from the Medicaid standpoint. That package of proposals, there were 79 proposals that were recommended by the Medicaid Redesign Team. A wide array, and I'll spend a little bit of time focusing on some of the larger items, but happy to answer questions later on some of the other items as well. Those ideas then went into the legislative process, as Rich said, was a learning experience for me. We went through in many discussions with the legislature on those items, and what emerged was that roughly 72 of the 79 items made it through that process. A number of other items were modified, and I think actually modified in some very important ways, and I think the legislature put a very good stamp on the proposal. Did we get everything that we had asked for in this process? And the answer was no, but we definitely feel like that the core of what the Medicaid Redesign Team was attempting to do made it all the way through that process, and now we're moving into the all-important stage of implementation. A couple of the key recommendations that emerged, first and foremost, is what it certainly is unique to the state of New York, and only a couple other states in the country have attempted this, which is to enact a global Medicaid cap, and also to give powers to the Commissioner of Health to, in essence, help to ensure that spending does not exceed that cap. This is definitely a major change in how the program is administered and managed, a much more activist approach to managing the program, which we are very excited to have the opportunity to have. Also, this is a major expansion. In fact, we estimate that roughly 1 million New Yorkers will have access to patient-centered medical homes as a result of this. New York has really led the country in encouraging physicians to re-examine how they provide primary care services, not just physicians actually, but also other mid-level providers as well, to really try to find a way to improve the quality of primary care that's provided. And patient-centered medical homes, there's a major expansion there in this package. Also, a theme that I think emerged early on was the desire to really continue the state's movement, although I would argue that in the last 5-10 years that movement has been fairly slow, towards getting out of the direct payment of claims business, the fee-for-service business, and moving into care management, or what we were corrected in terms of our use of the word managed care, but really to have the state move into an environment where virtually the entire population would be enrolled with some form of provider or plan who would have a responsibility for making sure that the comprehensive needs of that member were actually being met, that someone is being held accountable for outcomes as opposed to just simply paying paid for the more services that they provide. We're not going to be implementing that program on day one, but rather we're setting up basically a 3-year phase-in And we also are creating an advisory committee, particularly for the bulk of where the fee-for-service population still resides, which is in the long-term care and with some of the higher acuity, higher cost populations, to really continue to get stakeholder feedback to talk about what does care management mean for some of these new special populations. But that's a very significant initiative in this. Also, I think we were none too coy about our concerns about growth in the area of non-institutional long-term care services, whether it's personal care or home health care. There are some important initiatives there, and I want to thank the city, particularly on the personal care side, where there was an initial proposal that the city and others had some significant concerns about, and the city came forward with an initiative on personal care that we think is an effective balance between the needs to make sure that the long-term care populations do not go back into institutional settings like nursing homes, but at the same time try to put some controls in on costs in an area that really has been driving the budget. Also, in probably the most controversial elements of the entire package related to medical malpractice reform. The proposal, which was to enact a cap on non-economic damages of $250,000, and then also to establish a medical indemnity fund to pay for the health care costs associated with children who are neurological damage during birth. That proposal generated lots of discussion, and what finally came out was that the caps were not approved, but rather we are going to be establishing something of a one-of-a-kind fund, medical indemnity fund here in the state of New York, which we think actually has a potential to not only benefit the Medicaid program, because over 50% of the births in the state are paid for on the responsibility of the Medicaid program, but also creates a potential for some savings across the healthcare sector. In fact, in the hospital sector alone, potential savings of about $320 million a year. And then finally, and I think something that didn't get all that much acclaim, but it's definitely something that we're interested in, and we've made some steps there. But as I said to a few folks earlier, we definitely want to make some more efforts is streamlining and making our programs more effective, easier to navigate, and allowing individuals who need these programs to enroll in them much more quickly. A lot of good things done here in the city of New York, but there's still much that needs to be done to ensure that people are getting the services to which not only they're entitled, but we frankly want them to get, because we think it's in the long-term best interest of not only the individuals in the program, but also taxpayers to make sure people are getting cost-effective care when they need it. So I think overall, we feel very good about the process. There's a tremendous amount of work that needs to be done. The Medicaid Redesign Team is not done. In fact, we anticipate its continued work to start addressing some of the more complex, longer-term initiatives, including the move to manage long-term care, exploring ways to increase access to affordable housing for members, which is often one of the key reasons people go into nursing homes, to look at payment reform, accountable care organizations, how do we encourage through payment reform the redesign of the healthcare delivery system to make it more efficient. There's a number of different areas where we're going to be working not only with the Medicaid Redesign Team, but also additional stakeholders that are being brought to the table, hopefully in a collective effort to address these challenging issues, with the goal being a final report due to the governor in November, so for consideration for the next budget. So that's the Medicaid Redesign Team in a nutshell, and look forward to your questions.
Thank you. Commissioner Robert Doar is leader of the Human Resources Administration, which is the city agency that oversees public assistance and Medicaid and much more. He's been there for how many years now? 8 years? 4 years. Oh, 4 years, okay. Yeah, that's true. You weren't the first one in the Bloomberg administration. And prior to that, Commissioner Doar headed up OTDA at the state under the Pataki administration. He's been a leader on the expansion of EITC and food stamp access and much more.
Thank you, Andrew. And thank you for having me. I've been here before. I love these events and opportunities to talk about important issues before active and intelligent crowds. And I also want to say a special word to Jason. Welcome. You've taken a big job with big responsibilities. New York is not as tough a place as they say it is. We want you to succeed. We're rooting for you. And we want to help. And I also want to congratulate you on your success and the Cuomo administration's success with the budget, and say that, as you said earlier when I first met you when I came in the door, was that the hard part is now beginning. Legislation is one thing. Implementation in these programs is everything. I note that as I look out in this crowd, there's more than a few members of my staff who work in the Medicaid program in one way or the other. And I assure you, Jason, they're not here to hear me. They want to hear from you. And state leadership and state guidance is going to be very, very important as we go forward. I also need to point out, just truth in advertising requires that at HRA I have responsibilities outside of the Medicaid program. And our programs, our responsibilities within HRA are really about eligibility determinations and home care and personal care. And I don't cover the entire gamut of healthcare issues in the city, and all the enormous changes that Jason is overseeing for providers really are outside of my bailiwick. So I will reserve my comments to the things that relate to HRA. Before I talk about the challenges ahead and the problems that Medicaid faces and potential solutions, I think it's very important to highlight what we have achieved. The accomplishments of our public health insurance program here in New York City that we at least want to maintain, consistent with that famous healthcare admonition, do no harm. We cover a lot of people in New York City. The most recent numbers, 2.9 million New York City residents are covered by public health insurance. We are especially good at covering children. Our uninsured rate for children is less than 6%. That's the lowest rate of any major city in the country. It's almost a virtual universal coverage, really. You can't do much better than that. And these achievements did not happen by accident. They are the result of a lot of work by many people at the state and in the city, by community partners, by innovative uses of technology, by efforts in one of our offices at HRA is a vestige of something that began at the mayor's office and now is with us, the Office for Citywide Health Insurance Access, which is constantly looking at the data to find the holes. Where are people not covered? And what do we have to do as a city altogether to ensure that uncovered people make their way to Medicaid coverage? I should also say in New York City, and I want to say directly, that we are a leader in that unfairly maligned area of healthcare policy, community-based long-term care. Personal care in the home is usually less costly than nursing home care and provides far greater dignity for the recipients. And while some would say that we have been in the past insufficiently concerned with cost in personal care and long-term care, and I think there is truth to that, we believe that in more recent years, great progress has been made in getting costs under control in the personal care program. And when we look at data, we'd like to look at the most recent period of time so we get the full picture. So as we go into this exciting world of big changes in healthcare policy and Medicaid redesign, and changes also coming from the President's healthcare reform, I guess my number one worry is that we not go backwards on coverage, and we do not go backwards in our ability to provide home-based long-term care. So let me just start with a few remarks about changes coming from the federal government, if I may, because it is an important something to put in context. The largest group of low-income New Yorkers who are not covered are not going to be covered by the federal changes. The federal changes do not offer help to undocumented immigrants, which are the most difficult population of uninsured for our Health and Hospitals Corporation. And I think that's an important proviso to keep in mind. And on the other hand, and I'm very interested in this sort of middle class, low income, poor topic that came up, and I think I want to do some thinking about that. I do think that there is opportunity, great opportunity in the federal changes to provide greater relief and support to middle class New Yorkers who earn too much to qualify for Medicaid, but not enough to afford health insurance. And I think that's nice. I think that's a good thing. But I run an agency that focuses on the poor, and when it comes to coverage for them, I want to be sure that we continue to meet their needs. And I think that that leads to one of the big changes that wasn't so much highlighted in the Medicaid redesign efforts, but one that is out there, and it's part of the terrain that we're all going to deal with, and that is the shifting of responsibility for the determination of eligibility for Medicaid from the City of New York to the State of New York. That was part of a previous budget process in the Patterson administration. Work has been done on that. It's very consistent, in my judgment, with what the federal government is looking for in the new exchanges and a seamless interaction between programs that cover people in Medicaid and programs that cover through the exchanges. So the ball may be rolling too fast and is too strong to turn that back. And at HRA, we just want to make it work. And so, but it does raise very difficult issues. And that shifting of responsibility is something that we have to manage very carefully. And I look forward to working with you, Jason, and your team on ensuring that that takes place. With regard to the home care issues, I have one issue I would like to highlight. I absolutely, it's hard not to acknowledge the potential for good outcomes that would result from better care management or managed care. I can't not acknowledge that. It has great potential. It has great promise. But I would I want to be sure that we achieve that promise, because managed care plans can also cost more than personal care plans. It can happen that you can be in a managed care environment and still have costs in the Medicaid program that are unaffordable or beyond our means. And I believe that there is, it has the advantage of language. Whenever the thing is called something that sounds good, it has a benefit. And managed care or care management, I don't know, I guess wow, that sounds good. I want to make sure it is good, and I want to make sure that the people that we serve are covered in a cost-effective way and properly. So I do want to just strongly emphasize that the relationship between the city and the state in these issues is extremely important. And we at HRA have a long history of working collaboratively with our partners in the community and also with the state to make changes work successful. And we are committed to doing that. At the same time, we also have a role in determining eligibility, which we think we've done pretty well, and we want to maintain those achievements. So with that, I'll stop and look forward to the questions and comments. Thanks.
Okay, so I'm going to quickly invite up our panelists and our moderator. We'll start at the next to Commissioner Doar. Alyssa Aguilera is a community organizer for the Health Justice Program at New York Lawyers for the Public Interest, and has been working very closely on healthcare and the civil rights aspects of that issue. Barbara Lyons is a senior vice president at the Henry J. Kaiser Family Foundation, and she oversees and directs the Kaiser Commission on Medicaid and the Uninsured. She's been doing work on healthcare coverage and access for low-income people for several years, having worked at the Commonwealth Fund previously, and we had read some of her materials in putting this together and didn't imagine we'd be able to get her to come, but I'm very glad you have. This is great. And Betsy Lynham from the Citizens Budget Commission. She is now Vice President and Director of State Studies at CBC, based up in Albany. Our moderator, Anna-Mona Hardakalis, is a Metro reporter focusing on the healthcare beat these days, having covered public education and many other issues for the last decade. It's in your hands.
So I thought we could start with a kind of open-ended question and see how it goes. But I'm curious who each of the panelists think were the winners and the losers in this Medicaid redesign. So maybe you could each nominate a winner and a loser? Or could we try that?
Sure.
All right, I was thinking we could start at that end. Yes, thank you.
All right, well, I can start. It's kind of hard for me to imagine how I would answer that question. I really think that my hope is that one of the things I would say that I'm proudest of, and I hope I would say is a winner in all of this, is that unlike a lot of other states that are making efforts to actually cut back on eligibility, to make, as part of the difficult budgets, we're seeing more and more states, Arizona in particular, 250,000 people that lost health insurance coverage in Arizona. My former state of Wisconsin, probably somewhere in the range of about 70,000 adults going to lose coverage. But here in New York, despite our difficult budgetary times, that we haven't cut eligibility, and I think so that for the case of the uninsured and the people who are on the program, I think are winners as a result of that.
I guess I would say, as the budget person on the panel, that one of the winners was the governor in terms of having the unprecedented authority now to put the cap on Medicaid for a couple of years to try to keep costs down. As we'll talk about hopefully a little bit later, there are a lot of choices within budget making, and there are trade-offs. So you cut one thing, the others, don't suffer, or they do suffer. So it's very much an issue where cost containment was important to maintaining other priorities as well. So I think the governor, in terms of prevailing on the overall size of the package.
I'm not really qualified to speak to the winners and losers in this process, since I'm not from here, didn't participate in the process. But I did want to just make a few comments related to kicking off of Commissioner Doar's comments. When I thought about coming up here, the first thing I thought about is what has New York accomplished through their Medicaid program, and my list was very similar to your list. The coverage gains that New York has made over the past years stand way above many, many, many other states, and you should be very proud of that, particularly for kids, but also for other adults. Other states have just not made the kind of progress that New York has made. Again, thinking about home and community-based services, New York is a leader here, and again, that's a terrific accomplishment. Other states are now trying to think about how do we better serve people in the community, how do we reduce our institutional care, and I can tell you they'll be looking to New York for guidance from you and your accomplishments. So I think I'll turn it to you, Elisa.
Sure. So I would say that the losers would be consumers, and especially medically underserved communities, communities of color, people that really rely on Medicaid as a lifeline, ended up losing. I think if we look at how the process was moved forward, there were sort of these efforts to make it transparent and to be a dialogue and to include community voices within that process. But if you look at the actual proposals and who recommended them and what got approved, very little of what the community was saying, for those of you that went to the many MRT hearings across the state, made it into the actual final proposals in the final package. So I know that, talking to lots of people from community-based organizations, people that work with populations that are going to be directly affected by the cuts, people really didn't think that they had a voice, and that they lost in this process and felt really left out of this process. And in terms of the winners, I would say big private hospitals, people that had a lot of decision-making power in that process, the governor, of course, and people that stood to benefit from the proposals that were approved.
I would say that one of the potential big winners are the taxpayers. I think that we have to acknowledge, even for someone who runs a program that is very aggressive in enrolling people in Medicaid, that the program is costing a tremendous amount of money that may be unaffordable in the long run. I also run programs for the poor, like cash assistance or food assistance or domestic violence programs, and they are dwarfed by the Medicaid program. And I've had the feeling for some time now that every spare dollar that could go to help low-income New Yorkers goes to that program at the cost of the other programs. So I am hopeful, and I had some idea that maybe we could have a required redirection of savings from the Medicaid Redesign Team successes to programs that have not done as well in the fiscal picture in recent times. So but I do think there's great potential for savings. So there is a winner, and I hope we can deliver on it. And the losers are providers of health care. I mean, we have to be honest about that. Hospitals and doctors and nurses and long-term home care providers are going to have to deliver service with a less global amount of money available, and they're potential losers. Now, I have to be honest about that as well. As one who stands and works in programs that serve for poor people who are trying to get jobs or domestic violence services, I have a little bit of, I don't feel that bad for those healthcare providers. I have to honestly say that. I want to be honest about that. My sympathies aren't that great. But that's why, but those are all potentialities that are very dependent on the next several years and the state's leadership.
Okay, thank you. I'm going to try to parse the answers a little bit because we have an interesting disagreement here. I think some of the panel think that the governor and the hospitals were the winners, and some panelists think that, as Commissioner Doar said, the hospitals and the providers may be the losers in this. So if we could start by addressing something that James Helgerson talked about, the Global Medicaid Cap. I think we could kind of discuss winners and losers there a bit, but if you could explain what that means first.
Sure. What it means is it's sort of there's really sort of two caps. One is a cap that basically is associated with the next 2 years, and that's another interesting, I think, important reform, is that Medicaid is now going to be a 2-year appropriation, which actually extends the amount of time you're administering the program, and also extends your time and planning horizon. I think one of the biggest problems governments face is they're always under the gun to hit balanced budgets each and every year, and they have very little flexibility, and they have to basically enact fairly draconian measures to generate savings in the fiscal year. You have very little wiggle room. This gives us a little bit more of a longer-term planning horizon, which I think will help us to implement and maintain the cap. But the cap, in essence, is it's a fixed dollar amount that we have to spend on the program. It's sort of independent of any other factors that might otherwise come to be. There is some flexibility in the cap in the sense that the director of the Division of Budget has the ability to make some adjustments in the cap depending on some factors, but generally it's the dollars that we're going to have to live within. What is unique also is that we have flexibility to administer the cap, so we don't have to go back to the legislature to make certain changes to help control costs and control utilization. And that's going to be one of those, a new power the administration is going to have to figure out how we're going to do that. We're also going to be monitoring expenditures in the program far more closely than we've ever done before. We've been working very closely with colleagues in a number of different areas to put together a comprehensive budget tracking document that'll be much more detailed than we've ever done before. We'll be providing that to the public through our website. But it's going to be much more, as I said, activist approach to managing the budget. That said, there's also a 4-year cap, which basically from beyond this 2-year horizon also basically tries to cap the expenditure of the program at the rolling 10-year average of the medical CPI, which is roughly 4%. So that's in essence what we're hoping to do is basically control the growth at 4%, which we think is achievable.
So if you could explain that, the cap then is a cap on growth in spending, not an actual reduction in current spending.
The state share and the all funds, or what's called the gross spend, from last year to this year, there is a very small, very modest actual reduction, less than 1%, like 0.6%. From that point forward, next year, the Medicaid budget's allowed to grow by, in essence, 4%. And then, and those $2 numbers are actually in the statute. And then from that point forward, it grows at the 10-year average of medical CPI, which is approximately 4%.
Mm-hmm. Okay, and I'd be curious to hear from Elizabeth Lynham about her view of the cap and what it really means for hospital spending and provider spending.
Well, I think the cap is one of those items in the package itself, as Jason was talking about a finished package. I mean, it's not quite finished in that the cap itself is going to have some ramifications for how we deliver care. Right now, it's broad authority to bring costs down, and yet we don't exactly know how it's going to be applied and what that will mean ultimately for rolling forward with the services that are in the program. So it's an open-ended question as to, I mean, if it's described as an industry-led effort where the providers themselves figure out how to contain costs and try to submit lower bills, and if they don't, then the amount is, under the authority of the Division of Budget and the Department of Health to take it down. I think, although the legislature added some reporting requirements in the final adoption of the budget, we'll need to study exactly how that happens. If it's just so easy for providers to cut, it's $600–700 million in a year, I think we're really going to want to know how they did it and what that means for, these sectors of care that we have under the program. One of the things that we talk about a lot is, we sort of make broad brush generalizations, but the Medicaid program covers a broad variety of items. And, when we look at it, for example, we talked about eligibility. It's great that New York State has insured as many people as we do, and we're up high above the federal poverty level, 400% in the case of kids, and that's awesome. Kids are cheap. They're $2,300 a year to put on the program, right? Nobody beefs about that, or they shouldn't. Where we have the costs in the program are long-term care. 72% of the dollars in Medicaid are spent on long-term care. And so there are questions outstanding about how we go forward with that. Furthermore, we're not getting the best care. One of the items that we'll all have to look at too going forward, and I'm sure Jason will as well, of course, is the quality cost connection. Recent Commonwealth survey, a state scorecard, we're ranked number 21 among states in care. Although we have the largest Medicaid program in absolute dollars in the country, second largest per beneficiary, and we're 64% above the U.S. average on a per beneficiary basis. So we're paying for a Cadillac and we're not getting one, and we're not using those huge dollars to leverage more effective health care. So I know that was long, but...
Thank you. So to Elisa Aguilera, you mentioned hospitals, I believe, as a winner. You put them in the winner category. Am I correct about that?
Well, I would say certain hospitals. So in terms of safety net providers, so safety net hospitals, which are hospitals that that take care of a majority of Medicaid patients or uninsured patients, that I wouldn't put them as winners. But in terms of some of the big academic medical centers, those are the ones I was referring to.
And did your point here have anything to do with the global cap? And the hospitals agreed to this global cap. Is there something in it for them, at least those big academic medical centers, as you see it?
I mean, I think that, kind of referring back to that this is something that's going to have to be coordinated amongst the hospitals themselves, and that voluntary cuts are going to have to come from within the industry, and the industry is going to have to work together. And, if you look at the sort of the power dynamics and types of providers, I think that something that I'm worried about is the potential for certain hospitals, certain providers, certain communities, certain neighborhoods to sort of take the brunt of those cuts. And I'm not sure exactly how that's going to move forward, but it's obviously something we want to pay close attention to and watch and monitor.
So if we could talk about what Elizabeth Lynham mentioned as transparency, when the hospitals going forward make their cuts to meet the global cap, will we, as taxpayers, know what those will be, understand what those cuts will be?
Sure. Just to be clear, the industry-led cost containment initiative is not designed and doesn't imply that rate reductions or service reductions would be made by hospitals. Rather, what it says is it's a challenge to the industry, to not just hospitals, but other sectors, to really work together to really try to improve outcomes, lower utilization, and lower costs. Mm-hmm. And there are some initiatives that are already ongoing, that hospitals are working together to reduce things like readmissions and inappropriate hospitalizations, where New York ranks 49th in the country in terms of inappropriate hospital admissions. And so there's work to be done to improve the quality of the healthcare delivery system, and there's some good things going on right here in New York City. And so I think the idea is to try to identify some of those in the coming weeks and months, to see what we can do as a state to help encourage those, and that as a result of those efforts, in addition to all the other things that the state's doing, that we won't need to utilize any of the additional powers to control and keep spending within the cap, because we will see costs growing at a slower rate than what we might have feared earlier.
So you'll see savings from efficiencies and better quality? Is that what you're
yes,
saying?
I mean, I think there's I think there's a lot of good things about the New York healthcare system, a lot of things we can be proud of. There are still areas where a significant improvement is necessary, and I think that the industry and folks realize that that's the case, and if we can achieve those efficiencies and savings, we can lower costs in the program.
So can you tick off some of those efficiencies? You mentioned revolving door admissions, I guess. That's
sure. Yeah, I mean, as I said, 49th in the country, and a lot of that problem is right here in New York City. And so the question is, what can the hospitals particularly do, given their leadership role and the resources that they have, to work together with other providers to ensure that when someone comes out of the hospital, they've got a discharge plan that makes sure that they're getting the home health services, or they're getting, that they're filling their prescription, or that I think there's definitely more that can be done. And I think the hospitals are acknowledging that. They can't do it on their own, but I think that they have broader shoulders, and I think they also realize that if we do have to make significant reductions mid-year, that given the timing, that a lot of those reductions will have to be made in the hospital sector, because within healthcare, they probably have the broadest shoulders and ability to absorb those reductions. So I think there's a lot of pressure on them as a result of this cap to reform.
Barbara Lyons, is that a realistic goal? Have you seen this work in other scenarios?
Yeah, but we have not seen the adoption of a cap, a global cap, in many other states. So this is different here. But we do see, when we track what kinds of actions states are taking every year as they try to meet their budgets, closer budget shortfalls, we see a lot of cuts out there. A lot of provider payment cuts for multiple years in a row now. And that is the first place that states go to for cuts. But the interesting thing, I think, this year is that besides that, because there's not that much further that states can go to keep cutting rates and still maintain access for beneficiaries, we are seeing a lot of states now really starting to look at the service delivery system and really focusing in on can we provide care in a better, more efficient way. Hospital readmissions is a prime target for that, and so we do see a lot of states trying to focus in on that. Establishing a medical home for people so that there is someone helping them to coordinate their care. If you can do that and reduce those hospital admissions, you can get some savings, relatively quickly. So we have seen that in some states. The broader changes that I think reach more into the long-term care arena, we also see a great deal of interest among states. Other states are less far along in terms of thinking about what that might look like, and I think those kinds of changes take a little bit longer to get in place and get the community behind. But we do see interest in that across the states.
Thank you. Commissioner Doar.
With regard to the cap, I just think that the most interesting aspect of it that should not be ignored is the transfer of responsibility from the legislature to the executive and the 2-year extension. Depending on your view of the quality of the New York State political process, you and your confidence in Governor Cuomo and his team's commitment to serving people in need, that could be a good thing. I mean, I have to say, the political dynamic with regard to the Medicaid program is greater than we recognize, I think. And to some extent, what has happened at the state level is the governor's team are trying to move it out of that and give the managers of the program some breathing space to make some decisions. And I think that is worth trying, from my personal perspective. But, so that's all.
Well, that's an interesting point. The legislature is supposed to express the will of the people, and if certain decisions about Medicaid are being shifted from the legislature to the executive branch, is that going to affect New York's willingness to cover perhaps expensive yet needy populations? Is it going to affect what has been termed New York's level of generosity? Somebody?
Yeah, I can just clarify that we would not have the discretion to limit eligibility for the program, so that's important. That that's not a power that the state, the administration would have. So in that sense, there's that protection that would require an act of the legislature. But certainly I can tell you at least our intent and our actions will speak far louder than my words. But our intent is to try to utilize these new powers in ways that, as I say, actively manage the program, try to identify areas where costs are growing faster than what's appropriate, try to institute measures that will control that utilization, will control that cost growth, live within our means, but do it in ways that really try to minimize the impact on consumers.
I want to hear from Elizabeth Lynham on this because it's a budget issue, but I also want to add a thought. I'm thinking back to when I looked at the Medicaid Redesign Team's 79 proposals, and I remember that there was a term, something like rate recalibration, that was used quite often, and I wondered whether that was a euphemism for cuts to providers. So maybe Elizabeth Lynham could address that.
Right. Well, there's three basic drivers in Medicaid, and they're the number of people you have, which is eligibility, and there's rates and utilization, which is use. And rate recalibration, to my way of thinking, would simply be where we have rates that are very high compared to norms, which we have in the nursing home sector, rates that are 200, 225% of the U.S. average, where they're, more than double, and nobody exactly knows why. We have an antiquated system of payment to them, which means that two nursing homes situated on opposite corners in the same neighborhood with the same case mix, the same level of patient care, have radically different rates. So our rate system is very messed up, and yet we all know that some areas they're very high above the U.S. averages. So some areas there needs to be very targeted rate reduction. Hospitals, we don't have as much of a problem with the rates. We've been cutting them for the last bunch of years, and there may be 25% above the U.S. average adjusted for case mix and cost of living. But we have a use problem, right? So as Jason's saying, we have these unnecessary readmits. We have the highest cost index of any hospital use state. We have tons of procedures. If you look at some of the studies, NYU Medical Center jumps up as, the highest use of anyone in terms of care intensity. We are having a lot of numbers of days for people, and yet the care is not so good. So, there's all different ways of parsing it. Eligibility, we're not able to really touch. I mean, we want to take federal money through 2014, and so we haven't really suggested much eligibility change. Now, maybe we can engage with the federal government in some discussions of waivers, as some states are doing, to do some model programs and try to do some of these more avant-garde type care programs and change our mode of care, particularly for the elderly and disabled. Because it is possible to deliver less expensive community care and still serve people, right? So it's not a question of cutting people off necessarily. But I also have to say something about the elephant in the room, which is the $10 billion budget gap that the governor had. That's a reality, and we had the most major problem of losing $5.5 billion in federal stimulus aid from last year to this. Medicaid alone lost $3.5 billion. And if we look at the choices in the budget, Medicaid is going down $1 billion year over year. So they got like a $2.5 billion coverage on their loss in the federal aid. Schools did not get the additional coverage. They're getting a $1.2 billion year-to-year cut. So there are very clear choices. And as you track these priorities, you see Medicaid growing at 6.6% a year over 10 years and school aid growing by 5.4%. So, you know, you could say we could raise taxes, but $5.5 billion in loss of federal stimulus aid is a lot of taxes to raise.
Thank you. I see Elisa Aguilera leaning forward, and I was thinking of you now. Maybe you weren't. I am wondering whether people in some neighborhoods will suffer as a result of these proposals. Will there be neighborhoods where people will find it harder to get care, perhaps because of the proposal to encourage consolidation of hospitals closing and mergers?
Sure. So in New York City, where I primarily am focused, is that you have really medically underserved communities. You have certain neighborhoods that have taken the brunt of the hospital closures in recent years. Then you have places where there aren't primary care physicians, there aren't providers, and something that we're really worried about with the, you're mentioning a proposal that basically would provide funding to close or merge hospitals that are financially unstable. And for those, most of the ones that are the most broke in New York City are safety net providers where you know, people are on Medicaid or uninsured, go to get care, and so what? Yeah. So something that we're very worried about is not only the 2% all across the board cut to Medicaid, because if you're serving more of a Medicaid population, 2% cut is going to hurt you a lot more than if you have only a small percentage of Medicaid patients that are coming into through your doors. So that's something that we're absolutely worried about, and we're also worried about the way that that there's going to be incentivizing to closing and merging safety net hospitals. And we were hoping that the Medicaid Redesign Team would instead, provide monies or provide other sort of incentives to bolster safety net providers, because the last thing that these communities need is less health care. So yeah.
James Helgerson, are we going to see hospitals close and merge?
Are we going to see hospitals close?
Jason, I'm sorry.
Yes, I would say, I think there's a possibility that pretty much regardless of what we would have done with regards to the Medicaid Redesign Team, that there are some hospitals in the state of New York that are, and in the city of New York, that are definitely financially challenged. In fact, there's some analysis being done at the state right now looking at trying to identify some of the hospitals that are potentially most at risk of that. Well, I think what we tried to do with regards to the MRT was to give the state some tools to manage those closures. I think we've had some recent experience with some hospital closures that have been I would say not well managed for a variety of reasons. We try to give ourselves some tools. Some of those proposals actually didn't make it all the way through the process. They didn't come out the other end of the budget process. That said, we definitely want to work towards that and make sure, but I think we need to also encourage communities, and the state needs to take a leadership role in addition to the city to look at some of these communities to see if we can take a look. We have particular concerns about hospital access and the hospital situation in Brooklyn. And whether or not the situation there is stable moving forward. And that's just one example, but we also have some issues upstate as well. So I think it is a challenge, and it's not just the MRT, but a whole series of things over many years that have put some of these institutions at risk. And I would say, yes, there's a chance there's going to be some closures in the near future.
And what's the outcome for the people who are served by those hospitals? Well,
the question is that, so if a hospital closes, what happens to the rest of the healthcare delivery system? Not every time when a hospital closes is necessarily bad for the system, in the sense that it can sometimes strengthen the other hospitals, in the sense that you end up with maybe a smaller number of hospitals, but potentially the remaining hospitals are stronger. Also, I think we need to start looking at hospitals in different ways. How can we use that physical plant in ways that better meets the needs? Maybe a hospital no longer is a full service hospital, but rather serves a more limited set of services, but continues to be a vital asset in the community from a more of a general healthcare standpoint. And I think those are the kind of discussions we're going to have.
Okay, we could spend a little bit of time on personal care. As Andrew said, most people think of Medicaid as an entitlement for the poor, but at a certain point in life, many people come to need long-term care, people with Alzheimer's, problems like that, who need help just taking care of their daily needs. And Medicare, which is the insurance program for the elderly, does not provide long-term care. And people tend to fall back on Medicaid at that point. So personal care with the aging population has become a growing industry, and one of the main drivers of the increase in Medicaid costs. The question is what will be done about that, and what will be the impact on that population. Robert Doar?
Okay. This is one of the areas which I think we have to work closely with the state to ensure that the changes that are put in place protect people's needs. And I think there's a very strong commitment from the state to make sure that as we move to more care management, that takes place. The personal care program in New York City, I have to say, by and large, regardless of the rules that allow someone middle class to spend down and get into the program, is still basically a program for poor people. It's not extensively used. And in New York City, we have been, with the state's support and participation over many years, been providers of that care. And so when you think of people who live in communities in New York City whose care might change as a result of these changes, there are people in New York City who have a type of care, a personal aide or a home health attendant, for a certain number of hours. And as we move toward more care management, the way that care is delivered, it may change, and it may change to be less costly, and it may change to be more effective at the same time. That is very much within the realm of the possibility. And that's what is the goal, I think, of what is coming out of the state's leadership, in which I think we all have to work together to make sure is clear. But it may not be always the kind of delivery of that care that people are accustomed to, so that it will be involve change, or that they might particularly like or prefer. But it may not. It may not. I think we worked with the state on a counter proposal on long-term care, and I think a lot is still left to be said about what the details in that are. And that's why I keep saying there's legislation, and then there's implementation. And it's a little too soon for me to be certain that the implementation isn't going to be positive for the city of New York. But I want people to know that this protection of the interests that are our city, whether it's eligibility or whether it's the quality of the care delivered for community-based programs, is something that HRA will continue to care about.
Is there abuse of that system, though? Do people
Depends on how
get it too easily?
Well, I would not say that. I think you'd have to ask the budget expert from other parts of the country,
Well,
because sometimes people call abuse a difference. In other words, whatever they're doing there is different than any other place in the country. It's an outlier. The numbers don't add up the way they do in other places. That could be abuse, or it also could be a better way of providing care. So I think it's true that we're different, right? We're different. I'm not going to concede on abuse.
And anybody else see the system as?
I'll just chime in a little bit. We did some analysis of this a couple years ago. The DRA of 2005 actually tightened up the federal standards around income eligibility for long-term care services, and so we did some analysis around that time, because we always hear this, that people are, gaming the system or whatever, and the data just doesn't show you that, on any kind of a large scale. I mean, yeah, sure, you can always find one person, or you can always find a story, but when we looked at the population more broadly, you did not find people who would really be able to afford nursing home care for an extended period of time. And I also think it's just important to keep in mind that, beyond personal payment, which comes first, there is nothing for people. So Medicaid is the only program out there right now to help people really afford these very expensive services that are just vital to people being able to function and continue to live, really.
Well, how much abuse is out there? I mean, when you look at this category of eligibility called medically needy, which is where you spend down your money and become poor and get into Medicaid for long-term care, not very many states have the option to do it. So it's an optional program. There are only 15 or 16 states that have that program at all. So it's a limited population. But we have 30% of the people in the entire U.S. that live in New York State. Now, our percentage of poverty of the U.S. is about 14%. So we know that there is some use of this category of eligibility that goes well above the poverty level. We just can't peg it quite to, there isn't any income level stats with sort of a Medicaid data run, but personal care, for example, we have very much a use problem, and it's a lot of a New York City problem. We usually prescribe in the evaluations 3 times the hours in New York City, about 30 hours a week compared to 10 in the rest of the state per person. It costs about $30,000 a person on average for personal care, which is cheaper than a nursing home. Nursing homes are about $52, so it is cheaper, but part of the issue there is trying to rein in use in a way that still supports independence, but helps more people use the program. We've in 5 years seen some declines in use, which you're paying more per person, you're serving fewer people. That's not the way you like to see yourself go. So, we have some loopholes. Now, as I said, eligibility can't really be touched, but there were some components of what the Medicaid Redesign Team recommended that tried to close some of these loopholes that let some of the upper income people get into the program. And one of the ones was rejected, which is the spousal refusal clause. That was rejected in the final package, so that's not going to change, and there's court cases and all other issues with that. But home care, for example, we had a loophole where there was no asset look back for asset transfers, and it was a way to get into Medicaid at an earlier point in your life of care in the continuum where if you went to a nursing home, you wouldn't be able to get in because they'd look at your assets and say if you transferred X amount, you can't get in, you're not eligible. In personal care, we had a loophole where you didn't have an asset test and you could just kind of get hours, and then once you'd spent down what you had, then you go into a nursing home and you're on Medicaid. So that I think was addressed in the package to some extent, although modified. And so there are some areas where we had some issues with what we allow. The community spouse, for example, the Deficit Reduction Act allowed us to go to $500,000 on what your home value in your home could be to keep the community spouse in their home. We went to $750,000. So we have already some provisions in place that protect the community spouse. So it's important to look at that too long term. We need to have people contribute to their care to the extent they can so that we can care for the poor that really need the program.
So I'd like to raise another topic, which is labor costs in New York. And labor was represented on the Medicaid Redesign Team. I don't remember, well, there may have been some proposals that addressed union wages, but clearly the high cost of labor in New York drives to some degree the high cost of care. How do you handle that?
Sure. I guess I would say that our view, particularly in the very service-intensive, labor-intensive areas like long-term care, our view is that we want to build a long-term care system that's efficient, that makes sure people get what they need, but at the same time we don't have levels of service above and beyond what people need. And that's a challenge moving forward for us to be able to effectively do that. But at the same time, we don't want to build a long-term care system on the backs of very poorly paid workers who have virtually no benefits And that's actually what most states in the country do. Personal care workers, if you look across the country, are very poorly paid, have very little, if any, access to health insurance or any other benefits. And I think a strength that New York has moving forward is that we actually have, particularly in areas like personal care, the workforce is unionized and they have better benefits. And there have been studies that show that when you actually pay this workforce a reasonable living wage, what you end up with is a more stable workforce that will be available, that can, we don't have high turnover problems. You'll end up with better quality. You end up with better outcomes because you're not relying on workers who are paid very little. And I think we really don't shy away from the fact that we believe that that's a fundamental tenet moving forward about how the system, in fact, should be designed. And yes, there's some costs there, but we think in the long run that those costs are balanced out by better quality and better outcomes. And hopefully, if we can get some of the other elements of the system to be more efficient, we'll end up with a better long-term care system. Now, the one other thing I just want to mention, and this is not a small point to be missed, would some of these what we call loopholes in the long-term care system. If we really do not address these, this program will consume us. I had one legislator tell me that on the spousal refusal issue was, in essence, middle-class people's portion of Medicaid. That's how it was described to me. If our country's future is that if Medicaid is going to become virtually, everyone in the middle class and down is going to be in the Medicaid program, we got to redesign what long-term care looks like for when the baby boom generation gets there, because otherwise state budgets are going to be completely consumed. So it's a major issue that we made some progress there, but there's still some work to be done to help close some of those loopholes.
Thank you. We're going to have to make a transition to the audience questions in a few minutes, I think, so you could start to prepare your questions. Somebody with a microphone will come around as you hold up your hands. I did see Commissioner Doar, were you shaking your head during the discussion of labor costs? Was there a thought that I should elicit there?
No.
Okay. And you did mention something about a city counter-proposal on personal care. Did you not, in your introduction?
We had, the Medicaid redesign process was fascinating to follow. Jason, you made great TV for those of us who watched it and watched you. When the original proposals came out, there was a lot of push toward mandatory managed care for people in the home care business. And we in New York City, in our personal care program, in the home care program, are not mandatory managed care. And so it was a little issue about our role, and also we don't have, as I said in my opening remarks, the same level of confidence that the state has. We hope to have the level of confidence, but we don't immediately have it, about the great benefits of managed care all the time in every situation. So we felt there was a way to help better control costs while still preserving a role for the personal care program in New York City. And that's what we talked about. And at the last meeting, Jason described that the city had a proposal. It was accepted as one of the proposals. It was not very detailedly described. And so that's why a lot of it is still left to be said. But there's sort of a placeholder there that says, we want to work on this together. We want to control costs in personal care. We want to move to managed care. But maybe we don't want to have an all or nothing world. That's how I see it, or at least immediately. So that's what that was about, and that's all I'll say about that. No, I'm not going to get into the labor cost issue.
Okay, thank you. I thought we should hear from Barbara Lyons one more time on the national perspective and lessons for New York, possibly.
Well, the only thing I want to make sure we touch on before we open it to questions from the audience, because we haven't yet, is the proposals being discussed at the federal level. You're very focused on New York tonight, but there is a lot of attention being paid at the federal level to the federal deficit, and that could have enormous implications for your Medicaid program. Congressman Ryan came out with his proposal from the Budget Committee. Gosh, was that just yesterday? Which included a block grant to Medicaid, which would save $771 billion to the federal government over the next 10 years in Medicaid spending. So that's a 33% cut to what the federal government would spend under baseline spending. So, you know, I think it's really important to pay attention also to what's going on at the federal level. And the block grant that they're talking about is, you know, a little bit different from the cap that we've been talking about here in New York, because a block grant would basically change the fundamental structure of this program, where the federal government matches state spending to saying, here's a block of money, and I think in the Ryan proposal they adjusted for population growth and some inflation factor, but it isn't going to be adjusted for the health needs or the spending in the state. And so if that block of money turns out to be inadequate, that places a lot of risk on the states, on localities. Here in New York, the localities are very important. Providers and the beneficiaries themselves. So I just wanted to put that on the table before we close tonight. So thank you.
Okay, thank you. Let's go to questions from the audience. I'm going to let the microphones figure out where is easiest to go.
Hi, Denise Sofel, recently with the State Senate Health Committee. And my question has to do with what are the sort of concrete policy levers that you see the Medicaid program has that changes the way that healthcare is organized and delivered in New York? There was reference to the fact that we are a very expensive state. We do a lot of reliance on hospitals, a lot of reliance on specialists, a lot of reliance on high-intensity care, and all of that is revenue to the provider community. So how does Medicaid use its levers, whatever they may be, to actually convince the provider community to make changes that are not in their financial best interest?
Right. I would just say that obviously as a payer, and Medicaid's the largest purchaser of healthcare services in the state of New York, that does give us some leverage. Not with certain providers, it's significant leverage in the sense that where Medicaid is is the primary payer, we have a lot of leverage. But with other providers where we're more of a secondary payer, or even tertiary payer, not quite so much, but definitely I think that as we look forward, and as I see the Accountable Care Act, it gives states opportunities to explore not only with Medicaid, but also with the coming of the health insurance exchanges and the flexibility states have in the administration of that, along with state employees, that the state begins to think in consultation with its local partners how it can use that collective leverage to try to drive healthcare system redesign and try to get to a more efficient, more effective healthcare delivery system. That's really our opportunity. There's nothing in the Accountable Care Act that forces states to use that flexibility. But I think here in New York, because of our unique political culture and progressive tradition, that we are well positioned to potentially lead the country in showing just how that can be done.
Can I make a comment on that? I want to just emphasize the increased leverage and role the state will play in the eligibility determination process with both the exchanges, which will be state-run, and with the intention to take over the eligibility determination process. That will be a lever that we feel in New York City with the fact that we've had a role in managing the facilitated enrollers and dealing with the community partnerships and having our offices, that we've had a role in ensuring that eligibility when as appropriately or properly or effectively as possible. That role will shift to the state as we go forward, and that will be an interesting process to watch.
So I remember Dick Ravitch saying when he came out with his report last fall that the system now, which allows local determination of eligibility, also allows local officials to play favorites or, bend the rules, or is that true in your experience?
Well, I work for the City of New York, and I think when people looked at the eligibility determination process across the state, experts, people from the state, others, when they talked about abuses of that process, they weren't talking about the City of New York with regard to denying eligibility. I think when he mentioned it, he did talk about having a uniform process that filled gaps in upstate, more rural counties where they weren't able to achieve the level of coverage that we've been able to achieve because of our size and our use of technology and our innovation. That's what I think he was talking about. So that was my answer. I would say that it's another topic for another day, but the quality review process for eligibility determinations in the Medicaid program is different than it is in, for instance, other means-tested programs, and that's worth looking at going forward.
Thank you. Next question.
Hi, my name is Jane Steinberg. I'm at the Children's Aid Society, and I just want to bring up something for a very small number of youngsters in the state, the foster care children. I believe it was still on the list to change the foster care Medicaid to managed care in the 3rd year. We have a lot of youngsters that are very ill. If they weren't with our wonderful foster parents, they'd probably be in a skilled nursing facility. I just ask that when you work on this, that you have the input of the providers and that we could work with you on that. Thank you.
Absolutely.
Thank you.
Thank you.
There's one right there.
I actually have 2 questions, pardon me. My first question is with regard to the U.S. Attorney's suit that's been filed against the city. Is there, between Commissioner Doar and Mr. Helgerson, is there an ideological difference? I understand where Commissioner Doar would fall on this argument, but does the state have a position on whether or not the city has inappropriately utilized services? That's my first question, and then I'll pose the second one.
I was wondering. Good one.
I was wondering if you guys could weigh in. Towards the end of the budget process, there was some talk about executive compensation in hospitals, sort of coming off of Carl Kruger and his associates. And I wondered if you guys could weigh in on whether or not capping executive compensation is a feasible, possibility for the state, or if that could help control costs at all. So those are my 2 questions.
I would just like to say that I don't know this person. I had nothing to do with her asking the question. I want to be clear on that.
Well, I think it's up to
That's
up to the state.
But the question's for you.
I guess I want to sort of stay out a little bit out of the litigation issue, other than to say that, as I've been going through this process, I've come to be aware of some of the challenges. I was saying this before this started. Some of the challenges that the city faces, trying to, in essence, ensure that there's appropriate utilization in the program. We believe, and I don't think it's ideological at all, there's a difference. We believe that we don't want to go back to a time when long-term care meant nursing homes. We want to maintain and reinforce home and community-based programs. We made a lot of progress in this state. We want to continue to make that progress. We just also want to have a long-term care system that's sustainable. And we think there's opportunities for some efficiencies and savings here in the city and all across the state. So I don't think there's an ideological thing. Obviously, we have the U.S. Attorney looking into some of the things of the past, but I'm more hopeful about the future, which is that I think together we can really look at redesigning the system to get to a more efficient platform. There's challenges and issues that we need to work together on. And then your second question was more of just limiting executive compensation. We did hear this through the process. I think that it's a little bit more complex. I don't know, to be honest, how much I think it would be more symbolic as opposed to really reining in healthcare costs in the sense, and others will disagree, but we spend billions and billions of dollars on healthcare, city of New York, across the state, $52 billion a year on just the Medicaid program. And so executive compensation is a pretty small part of that. And also in terms of enforcing it, would probably be pretty hard because people get paid a lot of different ways other than just salary. So
It does seem a symbolically significant thing thing possibly to do, though? Was it discussed as such?
Well, I think one of the proposals that we were interested in is for things like the charity pool, some of the dish dollars, the potential of basically not allowing for cost reporting to be inclusive. I mean, there's ideas that, you know, we're open to still looking at, but it didn't make it all the way through the process.
I think Commissioner Doar wants to respond on the lawsuit question.
Well, maybe people all know that this is our view because our position in the court papers we filed are public knowledge and people are aware of that. But I did want to make the important point, I think, that the issue really isn't about appropriateness of care, although we believe we make the appropriate determinations of care. It's about the appropriate use of the False Claims Act statute to police what we do. I think for those of us in the Medicaid business or the public assistance business that draw on federal dollars to help low-income people, we should recognize that if that litigation proceeds and the use of that statute is used in the way the United States Attorney is attempting to use it, that has very serious ramifications for the way in which we go about delivering services to people in need. And we don't pretend to be perfect, but we think the tool being used to address whatever issues we have is completely wrong. So I think people should look at that.
Not to be flip, but it's a little like getting a traffic ticket you don't think you deserved. Is that what you're saying?
No, actually, it's a little bit like being put in jail for something for a parking violation. That's really what it's like. It's worse than that.
Okay, another question, where are the microphones? There's a gentleman in a beret here.
When you Google
I'm sorry, you have to wait for the mic. Oh, you have, okay, sorry.
Yeah, my name is Judy Wessler, and I'm from the Commission on the Public Health System and the Save Our Safety Net campaign. And I thought I had clarified in the New York Times what our request for limiting executive compensation was about and what it was related to, and unfortunately, I believe Mr. Helgerson just misstated again what our recommendation was, which was to tie limiting executive compensation to the Medicaid reimbursement rate. And people might think it's symbolic, but it's not, number one. It's also an issue of shared sacrifice. You know, people are being hurt a lot by what came out of the Medicaid Redesign Team to not look at salaries of $2 and $3 and $4 million, not salaries, but compensation packages, which it's very easy to go on their 990s and get. You know, it's not hard. Crane's Health Pulse does it all the time, and that information is very available. So that's one piece that I think, you know, was overlooked, and I think the other piece that I'm concerned about is that, and Alyssa has been raising this, and I just want to add to what she said, this was an extraordinarily political process. And the people on the redesign team, many were there so that there was not an advertising campaign against the governor. So instead it became an advertising campaign in support of the governor because the Medicaid Redesign Team recommendations were things that the people on the redesign team wanted. So, you know, to not talk about this as a very political process, as something that really was meant to reform Medicaid, is a very serious problem. And it affects what happens with the safety net providers. As Alyssa was saying, you know, if you cut Medicaid across the board, and one hospital has 50% Medicaid and another one has 2% Medicaid, guess which one is going to be hurt? So you destabilize safety net providers, and in addition to that, we have $1 billion in charity care funds that 90% goes out the door with no accountability on it, and that came off the table for consideration because, again, the hospital associations didn't want to talk about it. And we stand to lose federal dollars unless we address that. So there are pieces that are really, really critical that should and must be discussed publicly, or else we continue in this, I don't know, la-la land.
So, okay, I'm hearing two interesting questions here. One is on the issue, again, of compensation and whether it's more than symbolic executive compensation, and the other is whether the redesign team was, in essence, hijacked by the Greater New York Hospital Association. So, and 1199, let's not forget them. So, maybe Elizabeth Lynham could take that, and then Elisa Aguilera. Two questions.
Right. Well, I mean, you have a $52 billion Medicaid program. You have a lot of changes that need to be made, many of which have been touched on tonight. You have a fiercely defended group of don't gore my ox, gore the other ones, it's a very political hotbed issue wherever you're going to touch the program. I don't think it would be wise to spend a minute of political capital or time debating limiting executive compensation. I mean, even if you didn't pay them anything, you probably, with a $52 billion base, couldn't do that much for coverage or anything else with that amount of money. So I would focus, political capital on the larger issues which need to be addressed. And as to the process itself, with the picture typically in New York State through the budget process being one of, I'm protecting my ox, you protect yours, everyone protects their ox, and a $10 billion budget gap which required some choices, even if we had extended the surcharge or raised the personal income tax by 10%. You have to set the priorities, and I think that, the governor is shrewd politically. He estimated that, he would rather have some with him than against him, and, I think you can argue that maybe more representation would have been good, but it was a short time period. He wanted to try to deliver. I mean, there are lots of reasons for it, and hopefully, as Jason has said, they're not done, so, things will continue on. There's a lot to be decided yet about how we go forward, so...
Sure. I think that probably the most disappointing thing about the Medicaid redesign process that it's such a missed opportunity. People. I'm not saying that that Medicaid is perfect and that how it was should continue. That's not what we're saying. We think that there definitely is wasteful spending, that there needs to be improvements and efficiencies, and at the bottom line, give people an opportunity to get the best care possible. People that can't afford it otherwise, and that use Medicaid as a lifeline. And I think that there are a lot of things that were missing from the Medicaid redesign process. If you look at Medicaid as a whole in New York, the vast majority of people on Medicaid are people of color. There was very little talk about health disparities, ending health disparities, and how we can make sure that we're improving health care for everybody. And if you look at the process itself, there were no public unions. There were no representatives from HHC hospitals that get a lot of funding stream from Medicaid. There was one person that represented consumers, and to say that this was a collaborative effort in a real way, and this was we were hoping this would be a great opportunity to make Medicaid program a lot better, and unfortunately, I'm not sure. I think that that opportunity was missed, and hopefully, as the process continues, we can remedy that. And in terms of the political nature of the MRT, I remember, we were scheduled for 3 or 4 days of meetings to sort of talk about the proposals, to get community input, and at the end of day one, it was approved, and Governor Cuomo was ready at 4 o'clock for a press conference. So to say that there weren't political motivations or sort of backroom wheelings and dealings doesn't make much sense.
Should we get Mr. Helgerson to respond to the backroom wheeling and dealing?
Sure.
And the very quick
I think the MRT, I think that is important to point out, is that I feel like in some ways this package in basically 3 months this process has gone through, we really renegotiated this package in essence 3 times. First was in developing the MRT recommendations, which were approved on February 24th. Then working with those same set of stakeholders to try to translate those proposals, which are 2, 3, 4-page summary memos that are available on the website, into actual statutory language. That's a big leap to get to that level of specificity. And that had to be done for the 30-day amendment, and so basically in about 5-6 days we had to do that. And then the next process was where the people's representatives, the legislature, Senate and the Assembly, had their opportunity to go through the process as well. So it's not, it wasn't as if the MRT was the end of the process. There was opportunities for feedback and dialogue from a variety of different people throughout. Was the process perfect? No. What we did, this process was modeled on something that I did in Wisconsin, and in that case, we had 5 months. Here, because of the nature of the state constitution and the budget process here, we had to do it in a month and a half. And then as a result through the budget process, total of 3 months. So we didn't get the chance to do as much as we can. The weather hurt us. We didn't get to go all of the meeting places because of it. We also had to build a process for accepting ideas as we were accepting them, which was quite a logistical challenge to try to manage 4,000 ideas that come in a variety of different forms. So it was not easy. And so I apologize for us not having been perfect, but I think that I like to think that the final product, which, as I said, does a lot to protect the 4.7 million people on the program. It doesn't do some of the draconian reductions that you see in other states. I think we found some creative ways to find some savings. It doesn't fix everything in the program. Far from it, lots more to do, but hopefully we've created some space for which to intelligently continue to work with stakeholders to implement some of these more comprehensive and complex items.
Okay, thank you. Other questions?
Hi. Can you talk a little bit about the Medical Indemnity Fund? And also, you said that there was going to be a shifting responsibility from the city to the state regarding determination of Medicaid. What impact, if any, will that have on the fair hearing process?
Okay, first off, in terms of Medical Indemnity Fund, what this proposal does is it creates a fund that, effective October 1, will enroll children who meet a very narrow definition and neurologically impaired children. The fund will meet basically fund the healthcare needs of that population of children, in essence, for the rest of their lives. It will provide an exceptionally comprehensive benefit to a wide array of services, transcending your traditional medical services. The idea is that it actually will lower medical malpractice premiums for hospitals and doctors. And the reason it does that is that when a child is harmed during delivery and there's a lawsuit and a settlement or a court verdict, the court has to, or the settlement has to try to predict the lifetime worth of healthcare costs, which is very difficult to predict. Courts tend to be very conservative in those settlements because you sort of get one chance at it. We think that by actually paying healthcare costs in real time, so as the services are generated, that medical malpractice premiums will come down. And then as a result of that, you'll have providers, hospitals, physicians who will find it easier to practice healthcare here in the state, and then also just overall lowering healthcare costs. And then your second question was about shifting of the responsibilities. This is something that sort of transcends the Medicaid Redesign Team. It really is majorly impacted by the implementation of health insurance exchanges, where although the state had started itself on a path towards the state, in essence, assuming more responsibilities. It's actually an interesting issue, the state role versus county role. We're one of the few states, I think maybe the only state, that has such a large contribution from local units of government to fund the Medicaid program. I mean, we're one of the few states that use property taxes, in essence, to fund the Medicaid program and sales taxes. So that's usually not the case. Usually the state share really is the state government's contribution matched by federal dollars. We also rely, a number of states do, although it's a smaller number now, they rely on counties, or in this case here, the city, to do the eligibility determination. While the city has done great things to enroll people, there are some significant downsides to our process. We have very antiquated eligibility systems. Here in the state of New York, it takes us 5 months, or there's a 5-month lag in terms of how many people are actually enrolled in the program. When I found that out when I got here, I was blown away, because I feel like when you're trying to manage the program, you're flying blind if you don't know how many people are actually on it for 5 months. In Wisconsin, it was a 3-day lag, and that seemed like a long time. I think there's some challenges there. The exchange will lead us to a centralization because the idea is a statewide exchange. That said, I think we can build a system that, in essence, tries to utilize some of the resources the city's brought to bear to actually, incorporate what I would hope would be an army of individuals, community-based organizations, local governments from across the state to really help us make sure that families don't fall through the cracks and that people are going without health insurance as we move to the exchange.
Thank you. Do we have time for one more? Yeah, one more question.
Hi, my name is Mary Lee, and I'm with CPHS and the Save Our Safety Net campaign. And so I've followed this Medicaid redesign process and the state budget process, for some time. And what's really disturbing, I think, is that out of the discussion is racial or ethnic health disparities. And other than, Alyssa's comment 15 minutes ago, but we've just had a panel for about 2 hours, and it was the last 15 minutes, I think. And not just this panel, but the many other panels I've been to, and how that word, that phrase is always left out of this discussion. But yet, if I raise this issue, you'll say, no, it's not, we address it. But when it comes down to these 6 weeks where policies are made or plans are made, decision-making time, and that phrase isn't said, then, I'll make the assumption that it's actually not a priority. And so I just want to ask Mr. Helgerson, as a policy Medicaid director, whether it is one of your priorities to not just have a cost-effective budget, but also to have a socially just budget. And if it is one of your priorities, then to please work with us to have a task force on preserving safety nets, because when we talk about safety nets, we're not just saying safety net. We're talking about eliminating and decreasing racial and ethnic health disparities. That's the connotation that comes with it.
Sure, absolutely. We don't say it enough, and we are committed to trying to find ways to eliminate the barriers and the issues associated with making sure that we do not have an unjust system where people based on their color and ethnicity are unable to access the vital healthcare services that they need. We also need to look at providers and making sure that they're culturally competent and finding strategies and reimbursement tools to encourage it. It's a complex issue that needs addressing. The Medicaid Redesign Team did create an item to begin to address this. I think this is one where we need to engage a group of stakeholders, and that's really our intent moving forward as we move into the second phase to identify those strategies. And it's my, you can say it's my words are only worth so much, but I think as a, I guess I could say that we're committed to working with stakeholders to try to find some significant strategies in this area.
Thank you, everyone. Those were great questions. I feel like you did it better than I did, and I appreciate that. And I'll leave this to Andrew now.
Thank you.
I just want to say thank you all very much for serving on our panel, and thank you, Anamona. And this was wonderful. Thanks for coming. Unfortunately, we have to move on out pretty quickly. So good evening.